Bismillahirrahmanirrahim. The topic of our discussion is primary sclerosing cholangitis. So, primary sclerosing cholangitis is a disease of bile ducts which results in inflammation and ultimately destruction of bile ducts. Unlike primary biliary cirrhosis, primary sclerosing cholangitis involves all bile ducts irrespective of the size, whether they are intrahepatic or they are extrahepatic. In almost 70% of the cases, the disease occurs in association with ulcerative colitis. The peak incidence of the disease occurs in 30 to 50 years of age, and it is more in males rather than the females, the ratio being 2:1. The pathogenesis of primary sclerosing cholangitis is poorly understood, but definitely there is an involvement of genetic factors and there is an increased incidence of disease in first-degree relatives. Moreover, certain environmental factors as well as infectious agents are considered to play the role in pathogenesis of the disease. So far, the widely accepted hypothesis includes the occurrence of ulcerative colitis, which affects the intestine. In such cases, there is a T cell mediated damage to the intestinal mucosa. The T cells invade into bile ducts and identify certain antigens present on the ductal epithelium of the bile ducts, hence resulting in the inflammation, which ultimately leads to destruction of bile ducts. So in primary sclerosing cholangitis, small ducts as well as intra and extrahepatic large bile ducts are also involved. Certain autoantibodies are also present in almost 60 to 80% of the cases, and these antibodies include anti-nuclear antibodies, anti-smooth muscle antibodies, and perinuclear anti-neutrophil cytoplasmic antibodies or PNK. PNK in this case are atypical. Atypical means that these PNK are different from typical PNK in a way that the typical PNK are formed against myeloperoxidase. But the atypical PNK target the nuclear envelope protein. These PNK are positive in almost 60% of the cases of primary sclerosing cholangitis. The histological picture reveals damage to intrahepatic as well as extrahepatic large ducts and intrahepatic small ducts as well. In the large ducts, acute inflammatory cells are present, which are neutrophils, and this acute inflammation superimpose on the chronic inflammatory background. A typical character of primary sclerosing cholangitis is formation of stricture and beads. So let's say this is a large bile duct, and fibrosis due to chronic inflammation results in formation of strictures in the bile duct, hence narrowing the diameter of bile ducts, and there are focal preserved areas as well. These preserved areas give a bead-like appearance. So these are the strictures and this is a bead. In the beginning of the disease, the narrowing of large bile ducts is due to edema, and later on the narrowing is occurring as a result of scarring and fibrosis. There is comparatively less inflammation in small ducts than the large ducts, and the typical character of small duct inflammation is onion skin fibrosis. Onion skin fibrosis means formation of concentric rings of fibrosis around the atrophic duct. As you can see here, this is an atrophic bile duct and it is surrounded by concentric rings of fibrosis. These are the concentric rings of fibrosis, typically giving it an onion skin fibrosis character. Moreover, the hepatocytes reveal a typical cholestatic feature which occurs due to retention of bile. Progressive primary sclerosing cholangitis culminates into biliary cirrhosis. The disease is asymptomatic in its early course and it is often incidentally discovered due to increased level of ALP as well as in the ulcerative colitis patients. Alternatively, the symptoms of primary sclerosing cholangitis include fatigue, right hypochondrial pain, and jaundice might also be present. The examination reveals hepatomegaly and splenomegaly, and in the later stages of the disease, the symptoms resemble the chronic liver failure which include ascites, variceal bleeds, and encephalopathy. The lab findings demonstrate elevated liver function tests, which include increased level of serum ALT and AST. Since it is a cholestatic disease, there is elevation in ALP and bilirubin as well. Hypoalbuminemia and decrease in clotting factors also occur in the late stage of the disease. Anti-smooth muscle antibodies, anti-nuclear antibodies, and perinuclear anti-neutrophil cytoplasmic antibodies or PNK are present in almost 80% of the cases. ERCP and MRCP are also done to identify the disease, which reveals the formation of beads and strictures in the bile ducts. So this concludes our discussion about primary sclerosing cholangitis. If you have any questions, do let us know in the comment section. Thank you.